Welcome. Welcome to our first concurrent session, Strategic Inclusion of Anti-Racism Practices in Health Professions Education, presented by Dr. Walker Tisdale III. Dr. Walker Tisdale III is a public health analyst in the Office of Behavioral Health Equity at SAMHSA. He holds a Doctor of Social Work from the University of Kentucky and is pursuing a second doctorate in health professions education at the University of Maryland. A recognized expert in suicide prevention, health equity, and training, Dr. Tisdale previously served as Georgia's Director of Suicide Prevention and as a public health advisor at the CDC, where he led HIV/AIDS initiatives domestically and in Africa. He enjoys collaborating on equity education, training, and suicide prevention. Dr. Tisdale, I turn it over to you.
Thank you so much for that warm welcome. I appreciate the introduction. So I'm so excited to be with everyone today and for this important topic and this important convening. As Danny said, the title of my topic is to present to you Strategic Inclusion of Anti-Racism Practices in Health Professions Education. And there is so much to tackle in this. So I want us to make sure that we have an interactive conversation as much as possible. I'm going to show you how we can do that. Can we have the next slide? So we're going to go over our learning objectives. As any academic person will tell you, we have to know the roadmap of where we're going. So we want to make sure we understand the intersectionality of anti-racist activities and behavioral health education within various health professions, articulate the drivers of the behavioral health workforce shortages, and we know that there are many, and their impact on society. And I'm going to also look to the audience to give some feedback on that. Identify anti-racist principles in the context of behavioral health education, and that includes training, development, professional development opportunities. And our last objective for the day is to be able to apply anti-racism practices in behavioral health professional education programs. So we're going to talk a lot about the intersection of anti-racism, behavioral health, professional development, education programs. Next slide. So when you see this symbol, this slide, this imagery in the presentation, that's going to be your cue to kind of give us some feedback or to respond in the chat. And I'm going to ask my colleagues to help me to monitor the chat throughout. So you're going to see this at least twice in the presentation today. And I want you to think, there are no right or wrong answers. I'm going to ask you to think of a response to a question I'm going to pose, and then we're going to kind of review what's in the chat a little bit for further discussion. So that's the interactivity I was talking about. Next slide. So before we begin, a few thoughts. In order to feasibly, and just to put this in some context, to reverse the critical behavioral health workforce shortage, we just did not get here overnight with this behavioral workforce shortage. It happened over time. But there must be a focused attention to the practices that foster inclusivity. Like, how do we get out of this ditch that we're in? And that includes embedding equity and integrating anti-racist practices. So in other words, there must be some intentionality. Inclusive health professions education strategies can make an impact at the undergraduate and graduate level to enhance understanding of the importance of and value for equity and inclusion among professionals, as well as arresting bias in service delivery. So equity seems to be, or health equity seems the big word of the decade so far. And what I am proposing is that in order for us to think about the next generation of health professionals and how do we reduce those disparities and workforce shortages, we must address the inequities, and we must address the biases that exist, whether it's on race, whether it's on gender, whether it's on sexual identity, all of the above. And collectively, I'm a strong believer that together we can do hard things successfully. Next slide. Okay, so this is a rationale in terms of for anti-racism in the health professions. And I wanted just to kind of, again, to put this in context, but to get us thinking about In the United States, increasingly, our nation is becoming more and more diverse, not just around race and ethnicity, but around age, around socioeconomic differences and distinctions, around the workplace and the workplace needs, and how our country responds to those needs. I think the COVID pandemic is one of the most recent national examples where we saw that there was an unmet need in the health professions of how do we care for people who needed it the most, especially in a global pandemic. And that was really a wake-up call to a lot of folks, not just in behavioral health, but in medicine, in education, in terms of how do we address the workforce, because there are significant workforce shortages. We know with addiction counselors, marriage and family therapists, projected well into the later 2030s, into the middle of the century. So this is exacerbated for more than 169 million folks in our country who live in a designated mental health professional workforce shortage. And if I can just give a caveat, this really came to, was resonated with me when I worked in the state of Georgia in particular. Shout out to the state of Georgia as a suicide prevention director. And Georgia is a very diverse state in and of itself with 159 counties. I think I probably have visited 110 before I left. There is in that those counties, many are rural, as in many rural counties around the country. And so with a health provider shortage, if the health provider leaves on vacation, or they become ill themselves, or they relocate, or even go to a professional development training, oftentimes it jeopardizes services. Services are shut down or paused because that one or two provider is not there to provide those services. And so this has real implications when we talk about workforce shortages, not just in crisis time, but in times when there is not a crisis present. Next slide. And so I cannot have this conversation about the strategic inclusion of anti-racism practices without talking about the impact of racial bias and discrimination. And I don't have to really say much because if you consume media to any extent, you've probably seen a lot of instances of racial bias, racial discrimination, gender bias, and xenophobia, the whole like on your evening news. But a researcher defines racial discrimination, so we're on the same page as definitions, recently defined discrimination as being unfair treatment of people based on their race or ethnicity. And in the published literature implicates racial bias and racial discrimination in the reduced mental capacity, lowered life satisfaction, poor self-esteem, and other mental health disorders. And so I wanted just to kind of pause here for a second, because we're not talking about tainted water, tainted meat. We're talking about really something subjective in terms of our socialization, our social culture, that really has real life implications that affects people in their self-esteem, their mental capacity, their life satisfaction, their quality of life. And this is something that I think is also borne out in some of the activities of larger organizations. More than 4 or 5 years ago, there was a designation by the head of the CDC that identified racism as a public health threat that had never happened before. So we know there is real data behind the impact of racial bias and discrimination. Next slide. So in talking about, and this is where I want to pull together, now that we've talked about racism and bias, I want to talk about who's part of the health professions. So who do I mean when I'm talking about that population? So the health professions include a wide range of people with different skills and different levels of education. And this is just a few of them on your screen. There can be others that people may identify that I have left off this list unintentionally. But from peer specialists to personal care aides, home health aides, certified nurse practitioners, of course, doctors and nurses and pharmacists, dietitians, nutritionists, psychotherapists, addiction counselors. So when I talk about the health professions, I'm really talking about it in the pejorative sense, broad-based. I'm not trying to be exclusive, but inclusive. Next slide. All right, so now let's put these together. So anti-racist practices in health professions education. this is something that I think we really need to give thought to as we look towards the future, again, in terms of how are we preparing the workforce? How are we preparing the next generation of workers, right? All of us will not be in the workforce, 100 years from now, hopefully, right? So we want to think about what needs to happen systemically and in the pipeline for the next generation to kind of do better than what we have done so far. Like every generation, we want to see improvement. And in the workforce, for health professionals, there's no different. So an analysis of the selected sources revealed that health professions educators engaging in anti-racist pedagogical approach requires more than incorporating racialized perspectives and content. This is very important. So to be an anti-racist practitioner, if you will, in the classroom setting, you need to do more than to provide content that is anti-racist. It really needs to really think about the whole structure of our system. And there are some interrelated components. So one, developing a critical understanding of power relationships. Again, we didn't get here overnight. So when we think about the history of the United States in particular, take our own country, and you think about how the power dynamics have been from the beginning of our settlement in 1776 to the civil rights era to today. And how have those power dynamics and power relationships either enhanced some populations' exposure to leadership and opportunities in health professions, and where are the health disparities? And when you look at the data around health disparities, it really does tell a story. So I here want to say now, don't take my word for it in this presentation, but really do your own research and find out where are the health disparities in your jurisdiction. How long have those health disparities been there? How have they been exacerbated from COVID and other national interests that have happened? And also, how do we move toward a critical consciousness? Meaning that in order to really adopt anti-racist practices, you must do something. It's not enough just to be a non-racist, right? It's not enough just to say, well, I don't believe in racist or racial bias or bias on gender or whatever it is, but I must do something to really address the inequities that exist. And so that's the challenge here as well. We want to do something because you're here learning and being present for this presentation, but where do you take it from here? Taking action at individual and organizational levels. And that's really what it's all about. Next slide. So how can we solve this national problem? And I think that there's a lot of consensus that that racism and the workforce shortage are national problems. And so one of the things I'm going to ask you to do is to think about what are some of the novel things that we can do either at the individual level or the systemic level. Next slide. And as you're thinking about that, I want to share with you. So I did in preparation for this presentation, I took the liberty of looking at a couple of just simple Google searches talking about workforce, behavioral health workforce, and or workforce shortages. And this is what came up. And I was really kind of astounded that there were so many articles that came up. So one is just not enough therapists for the state of Georgia. Georgia lawmakers aim to support mental health workforce. I'm sure there's many in your jurisdictions where you are. There's one from Texas. And then I think about where we see these workforce shortages, but also where do we see the disparities. So if I were to do an overlay of the map, and we can go to the next slide. So if I can go do an overlay of the map, right, in terms of where the workforce shortages are and where the health disparities are, we would really see what the exacerbated need is and how we need to respond. But this is part of that response. So the University of Minnesota here receives $1.8 million to tackle rural healthcare workforce shortage. The healthcare workforce crisis is already here, claims another article. And the city and state want to provide mental health care services, but a workforce shortage threatens those ambitions. So this is also having an impact, not just in terms of rural health, but in urban settings, but also politically, because when you don't have enough of the workforce, and again, I go back to the most recent example from our COVID-19 collective experience with the pandemic, we realize how truly at risk we are. Next slide. And this is another recent article from the governor of New York, who's announcing this is a huge investment in terms of nearly $650 million to recruit and train thousands of healthcare workers across the state of New York. So that's a huge investment. So political leaders, private public sector leaders are answering the call. They are responding. And so it takes a while, right? It's hard to turn a big ocean liner on a dime, but that's what we really need to try and do to address some of these health disparities. Because I would venture to say, what happens when we have the next epidemic or pandemic? What happens if we have another national disaster? You know, where I am in Maryland, there's a conversation, I'm sorry, in the South, there's conversations right now about being aware of the hurricanes. So we really need to be proactive in how we address the workforce issue, but also how do we address it in an ever-changing country that has much more diversity than ever before? And I would submit to you that includes the inclusion of anti-racism practices. Next slide. So to that point, how are we defining these practices? So we're all on the same page. And again, this is one context. There are many definitions, again, depending on where you are. But anti-racism actions can come in many forms, including individual, transformational, individual transformation, organizational change, and so forth. Anti-discrimination legislation, racial equity policies, the whole 9 yards. So we talk about anti-racism actions. Each of those examples there require us to do something. Again, it's not enough to just not be racist, but to be an anti-racist, really the call to action is to be active, is to be engaged. An action-oriented educational and a political strategy for systemic and political change that addresses issues of racism and interlocking systems of social oppression. That is definitely one of the overarching goals, is that we have work to do in this country, right? I know everyone here likes hard work, is hard work is good work, as I've heard someone say. And being action-oriented doesn't necessarily mean that you have to do it in a silo. As a matter of fact, it means that it probably and needs to be intersected with your employer or your community or your educational institutions and mental health institutions, all hands on deck. But the truth of the matter is that we need to really do this together and collectively. Next slide. All right, here's one of those examples where I'm going to ask you to do something and put it in the chat. So share in the chat examples of anti-racism practices in training health professionals. What have you experienced that works, or what works? So, and I'm going to share some examples that people are populating in the chat, and I'm really excited to see what you share. So when we think about anti-racism practices, it can be a number of things. And next slide as we do that. Awesome. It can be a number of things. So if you are an anti-racist trainer and you're doing trainings, some of the things to consider are, facilitation by qualified and diverse trainers. Training and development is one of the key go-to activities that employers have in order to build capacity and competency of their workforce. And so training is ever present. And with that, we have choices in terms of how we choose to develop our own learning and our own knowledge. And so making sure that there's representation for the qualified and diversified trainers, and diversification in terms of not just race and ethnicity, but of perspectives of thought, right? Perspectives in terms of how people live and exist in their communities. A brave and open environment for honest dialogue and self-reflection. This is sometimes easier to say than to do, because honest dialogue sometimes can create opportunities where people do feel safe enough to share what's going right and what's going wrong, or what needs to be adjusted or looked at. And you have to be willing to have that platform, to have that environment that is open, that is honest, in order to truly get applicable feedback, to get meaningful feedback. This is where I say, in terms of, I would encourage everyone to think about the workplaces where they work, the places where they worship, the places where they go for community engagement, and the places, honestly, to where you go for services. And is there a way for there to be an honest two-way dialogue and self-reflection on policies and programs that work and are supportive, and those programs that are not working or keep people out, that are exclusionary? Also, as a person who really does love research and academia, evidence-based, research-based curriculum with diverse perspectives is always paramount. Is really critical to think about when you're providing training and education and you want to really get people engaged in the material. It's really important to have some foundation. How is the information being presented? Is it based on current research? Is it based on research that has been inclusive in terms of its sample size or population? Has it been prepared or presented in multiple venues and forums that people are familiar with? And I'm a big believer is that, evidence and data does not have to be scary, right? We can break it down and have conversations about the data that we're referencing, because none of us are going to be around long enough to make all of the mistakes. So let's learn from the researchers who have gotten some things right and documented it for us. And we can keep the things that work for us, and the things that don't work for us, well, we can continue to look. And I think one of the anti-racist practices, just to keep in mind, and I'm just going to go to some of these things I see in the chat as well, but there's always a threat of termination. And so the trust level and power dynamics come into place. Absolutely, Mary. Jane said our HHS department for the county took a personal bias course together, and it was very revealing. Thank you for sharing that. I think these are examples, though, of where the work lies, right? Of getting down in the trenches together and having some tough conversations, or conversations that maybe we thought were tough, but we just haven't had them before. Next slide. Training principles to consider continued, focus on individual and systemic change. Whenever we go to a training, because I know that probably a lot of folks out there in the sound of my voice have been to 1,001 different trainings just since yesterday, and presentations, and we may even be zoomed out to some extent. But focusing on individual and systemic change is really important. So a good anti-racist training program focuses on both the person and the system that the person is involved in or engaged with. It also equips you to help to identify challenges and discriminatory policies and practices. Now, I will say this as a caveat: it's really hard to have these conversations and to have buy-in from individuals around how do we create an anti-racist system? How do we create an anti-racist training program? How do we create an anti-racist system of services if there's not a real commitment to follow through? So this is where there must be a focus and a commitment to the change. Practical tools and strategies for implementation. Effective anti-racism training goes beyond theory. It's not just a pie in the sky, like it's really a feel-good training that we all came out on the other side and we feel better about each other. That's great if that happens or when that happens, but it also provides people with practical tools and strategies. And what I mean by that, when I say practical tools, things you can use, things that you can go home after the training or after the educational session and say, we learned this and we can do this differently as a result of that. Things that you can put into action immediately. And we all want things that are practical, right? I used to think that when I go to the Chinese food restaurant, I would always order with chopsticks. And then I realized at the age of 47, I'm no good at chopsticks. So now I get a fork. Next slide. Implications for a discipline of social work. So I wanted to tease out of all the disciplines in the health profession, social workers. Once, because I'm a social worker myself, and I think social workers are superheroes as all other practitioners and folks in the helping profession. Is that the code of ethics for the social work, there's some social workers out there, I see the hearts. The code of ethics for the social work profession has called upon members to practice through an anti-racist and anti-oppressive lens. So it's within the code of ethics for an entire discipline, and similar among other disciplines for sure. In October of 2022, the NASW, the National Association of Social Workers, convened racial scholars and activists to build a vision for achieving anti-racist work. It resulted in a published document, Undoing Racism Through Social Work, which if you haven't had the chance to read as a resource article, get yourself a good cup of tea or coffee and a cookie and enjoy this reading, because it really is a great read and really good for thinking about how it can be applied in the workforce setting, not just for social workers. It was developed with social workers in mind, but definitely you can use this in a variety of settings. Next slide. So to continue with that, I want to talk about, this is from my friends at HRSA. I want to talk about in terms of the health professions, and specifically, again, teasing out social workers in the United States, just to kind of put this kind of workforce shortage in context for this one discipline. So there is a maldistribution. When you look at this map and you look at the rate of social workers that are currently active, this map was developed on just about 10 days ago, the maldistribution of social workers in the United States. So you can see the darker areas have more social workers there. The lighter areas have less social workers. And these show the extreme shortages in the southern region. So literally, if you look to the lower third of the map, you can see a lot of light blue there. That shows that really that when there are natural disasters or there are population shifts, there could be really an issue if social workers are not present. Now, again, this just takes into account one discipline. This doesn't take into account the doctors and nurses and so forth. But I thought it was interesting just to visually see that. Can I also show you something similar on the next slide? Next slide. So this talks about the diversity of social workers in all states. And surprise, surprise, social workers are a diverse bunch in and of themselves, coming from diverse representatives from different racial groups, ethnic groups, and the like, LGBTQ. But in terms of race and ethnicity, overwhelmingly, the discipline is white, right? And when you look at the breakdown and you think about, again, going back to the earlier conversation about disparities, look at the smaller slivers of the pie, right? So you have less than 1%, a 0.5% actually, of American Indian, Alaska Native social workers. And I bring that up in particular because we know that Native Americans, especially tribal organizations, are inundated with health disparities from addiction and substance use, from mental health disorders, disproportionately impacted by COVID-19, also have a great deal of mental health and depression and suicidality and risk for suicidality. But when you look at the smaller number of social workers that represents the population, it can be really undermining of the potential for intervention. And I raise that because there's another data study that I'm not going to bore you with, but just to give you a little citation, that says that individuals tend to receive better treatment or quality of care, a perception of quality of care, from practitioners who look like them. So this is true across the board. So white practitioners and white individuals seem to experience a better level of care. The same for African American, Asian, Native American. And so when you have such low numbers in the workforce of a specific racial group, there are implications there, as well as like, how do we replenish those in the workforce? So this is something that not only the workforce shortage itself, but the diversity of the workforce shortage is something that's really important and top of mind. Next slide. So the drivers of the behavioral health workforce, I could ask you to put this in the chat too, but I won't. But there is, what drives the behavioral workforce shortages? Again, we just didn't get here overnight. I'm not going to go through this entire list, but I'd be curious if there's something that you don't see on this list. If you'd be willing to put it in the chat, I would love to read that too. But some of the drivers in terms of educational burdens, credentials, student loan repayments, having the finances to actually get into a college or university if you're going to go that route to enter the behavioral health workforce. Because nearly all of the behavioral workforce credentialed positions do require some level of formal education, if you will. And if you don't have the funds or access to that, that becomes a barrier. Reciprocity and licensure restrictions. We saw this come up a lot during COVID-19. I also think too, I love the chat is just lighting up right now. I love that you're sharing so much. The social work being an unpaid internship requirement. Thank you, Claire. The former me is having a little bit of a flashback from that experience. Disability accommodations are not being met. Factors at system, organizational, and individual levels. And I also wanted just to give voice to, because our society is growing, population is growing, we have an aging workforce, but we also have increased needs for services. There's an increased needs for services in schools and in prisons and jails and at the community level. And so you can see that there's an urgency to this as well. Next slide. So a brief history lesson and discussion. So how did we get here? Next slide. So how many of you have heard of the Flexner Report? You can give me a thumbs up if you've heard of this before. The Flexner Report was published in 1910, and this is just one. It's not the go-to reason for all of the workforce shortages in America, but this is specifically points to the lack of diversity of medical schools and doctors of color in this country. So the Flexner Report came out in 1910 and was responsible by all accounts, or most accounts, for a closure of several Black medical schools in the United States. At the time, there were 7, including 5 of those 7 were closed. And there's a list there. And the reason, there's many reasons for why this was deemed to be the outcome. One was that the Flexner Report was supposedly working under the guise of creating a standard and trying to have medical schools that met a certain standard for their curriculum. And if you didn't meet that standard, then they were recommending that you close. Well, the issue was that there wasn't a lot of quote unquote technical assistance to get some of those schools who were deemed below a standard up to a standard. And the year that it came out in 1910, we know that there was deep segregation in our country at that time. So there was definitely going to be a disproportionate impact in terms of the production of medical students and medical scholars as a result. And I always think about, this happened in 1910, and we know that there's a medical shortage of physicians and physician assistants and nurses. And what could have been our status as a country today in terms of addressing those workforce shortages if those 7 medical schools were to stay intact, or those 5 of the 7 were still intact? We'll never know. Maybe we wouldn't have had the level of disparities that we have today. Next slide. So the residual impact I just talked about, the thing I'll just say, some of the estimates suggested that had those schools not closed, there may have been education for some 30 to 35,000 Black physicians over the past century. That's nothing to sneeze at. But I also think about what could have been the impact, again, on health disparities, and how can we mitigate the biases that were in the Flexner Report so that this doesn't happen into the future. Because there's a lot of conversation currently about what we need to do and how we need to kind of think about who we educate and how we educate them. And I think too, and Kathy, I saw your question in there. I'm going to try and get to it before, about the increasing censorship and pushback against DEI work. This is one of probably the biggest topics of our time in terms of diversity, equity, and inclusion, the kind of momentum and prosperity that's come as a result of identifying DEI as important in our work in behavioral health, but also in education and leadership positions in the private sector. But also the pushback is something that we have to also monitor and to have a response to. Because I think we all agree that there are no superfluous people. We all have a role. We all have value in our society, and there's room for all of us at the table. There really is. Maybe you have to let out the table and put a leaf in the table so we can have more people, but there's room for all of us. Next slide. And I wanted just to pull out, this could really be a full day presentation, but I promised the folks that I would not go a full day. The Hispanic, Latino medical workforce, talking about the African-American workforce, and specifically with physicians. Right now, today, there are almost 54,000 physicians in the United States who identify as Hispanic, but that's roughly 6% of all physicians in the country. However, we know that there are many challenges that face this number, and Hispanic Latino Americans represent upwards of 13% of the US population. So we know that there is definitely an unmet need in terms of physicians who are language specific and language adept in speaking the language of the native language of individuals who are Hispanic Latino, also who are culturally aware and culturally have culturally relevant practices. We also know that there are a number of issues and challenges regarding systemic barriers and just being able to meet Hispanic Latino individuals where they are in terms of, how do we offer culturally appropriate services? What are the hours of operation? How are we honoring their Spanish-speaking physicians, but also the younger Latina physicians in this country? But also, how are we addressing the disparities, those known and unknown disparities? Whether it be food insecurity. And this is where the conversation can really shift in terms of there's a role for the medical workforce, the behavioral health workforce to really elevate and try to address the social determinants of health. So even though you're talking to someone about, maybe an addiction issue, a substance use issue, a mental health issue, ask them, do they have stable housing? Ask them about, have they had a meal that day? Ask them about food security and insecurity. There's a role for all of that. And I think this is probably indicative in terms of with the Hispanic Latino medical workforce. It is a significant number, 6% of all physicians, but we know that number should and could be higher. Next slide. All right, here's another opportunity to put something in the chat. This is where I would love to hear from your examples of expertise. So examples of behavioral health anti-racism models. What works? Are you aware of a program? Are you aware of a program model or a service that's in your jurisdiction that's really been successful in addressing anti-racist, and I would even add that maybe even anti-xenophobia, anti-LGBTQ, anti-Jewish, addressing those issues in the work that they do. Because oftentimes we don't recognize in our work other models that we don't necessarily see, right? We talk a lot about, there's value in having representation. And I'm aware that the work is so hard and there's so much work to do that very few of us have a lot of time to go to our reference section and the library or Google or to our workplace and find out what models exist that really address anti-racism in the workplace and what has been working and what should we be trying, right? So if you know some, I want to ask you and invite you to share some in our chat now. There is, yes, you can invite me back, Heather. Next slide. So this is one I want to share with you. So at SAMHSA, I'm also the government project officer for an amazing Center of Excellence, the African American Behavioral Health Center of Excellence. They're located in Atlanta, Georgia. They're affiliated with Morehouse School of Medicine in Atlanta. And they recently presented on the self-assessment for modification of anti-racism tool. It's a simple tool that can be used to share with the African American behavioral health providers, but this tool can also be adapted to other racial groups. And what does the tool do? So this is when I say there's an opportunity to do something to be intentional. This is one step to be intentional. So it provides metrics to specific disparity and inequity and issues in a community behavioral health setting. So people are asked to do this tool and to work together either in small teams or individually or in leadership. I think would be a great retreat opportunity to do an activity around this. Extend beyond cultural competency and linguistic appropriateness. Like we know we need to have services in the language that's relevant to individuals. We know we need to be culturally competent and the value of that. But also, how do we incorporate that into the structure? How do we incorporate that to specifically address an inequity that we see? Promote a stepwise and concrete quality improvement process that could be adapted. So once you've identified what the issue is or what the inequity is, how can you use this tool to identify a response? And so this self-assessment for modification of anti-racism tool, SMART is the name, it really is about quality improvement. And so I really encourage you to think about accessing this. Again, it's at the website for the African American Behavioral Health Center of Excellence. It's on the SAMHSA website, or you can also just Google the African American Center of Excellence, and this should come up. And I put the resource link right there above as well. Next slide. All right, so now let's come back up to the issue of strategic inclusion. What do I mean by that? So when we think about anti-racism practices, we think about anti-racism practices as not as a monolith, excuse me. We need to think about it in its proper place and proper structure. And what I mean by proper place and structure is that we need to think about it as part of an institution, meaning in my role, am I in a position to work with our institution around systemic change? Am I in a position to talk about anti-racism at the interpersonal level or personally mediated racism? Or am I really going to just focus on me? Maybe before I do anything externally, I need to focus on myself and internalize racism or self-loathing. And we need to also think about how do we implement those anti-racism best practices, right? And this is going to sound very familiar to a lot of you. And so there is, and Ruby, I love this comment, the organizational level and policy. So when you think about implementing anti-racism best practices, I wanted you to think about the inclusion at the policy level. Does the organization I work for, the school I attend, or the community in which I live, are there policies or even laws that exist that are really anti-racist or have built-in bias that really could be addressed? What about personnel training and social structure, right? Almost every workplace, including universities and colleges, offer personnel training to students, training for faculty. And what can we embed in those trainings and personnel development sessions to really look at the best practices for anti-racism? And really, I'll let you in on a little secret. Oftentimes, just merely making the suggestion is really going to be helpful to people who are coordinating these events, right? So I bet maybe an employer or a training department or human resources would love to hear from you about what do you think about this. Emotional culture and affirmational and intentional support. So when you think about anti-racism, again, it goes to being proactive in terms of how do we affirm other people? How do we intentionally engage other people? I always say, if you see something, say something. So it goes beyond about, did you see what happened with the George Floyd incident that happened a couple of years ago? But really, what has happened here in terms of maybe you see, we have some biases in our policies about how long we can see patients who have maybe a language barrier. Maybe we need to address that. That can be an intentional act, right? So it doesn't have to be pie in the sky that we're going to change the world, but it can be at your level, what you see every day. Next slide. So some other examples of some anti-racist strategies. So I didn't want to leave you without talking about some specific examples and just to get your minds racing a little bit. So make anti-racist resources accessible and applicable. Think about, if you do not have this, make a list of anti-racist resources that are very specific to you and your population and become that resource internally. Talk with instructors and trainers about anti-racism learning activities. LinkedIn is a very good resource for this. Not everything on LinkedIn is appropriate, but sometimes I find some of the best subject matter experts that are not in my jurisdiction who have a lot of expertise that you can tap into. Consult with organizational leaders about anti-racism expectations. So having the conversation. I'm going to just skip down because I really think this is also important. Third from the bottom, audit existing policies, protocols, and access tools for racial bias. Take a look and see, let's do a 360 scan internally. What are our policies and protocols that are prohibiting people from really getting the best out of our organization or getting the best out of our training or getting the best out of our services? Let's really look at that. What have we heard complaints about, right? What do we need to address? Working collaboratively and strategically. And I always am a big believer that if you can gather consensus every step of the way, you will have less pushback when it comes to implementation. So gather consensus wherever you can. Next slide. Here are some SAMHSA resources. Of course, I'm going to plug what we have at SAMHSA because, SAMHSA has a lot of resources. So SAMHSA had a behavioral health workforce expert panel. One of the things you guys probably already know that federal government is really good at convening meetings. We had a meeting in January 2024 around the behavioral health workforce. And out of that meeting came a number of suggestions that you're going to be hearing a lot more in the public soon about what we can do to address the workforce shortage in behavioral health. There's an issue brief that came out in June of 2024, expanding peer support and supporting the peer workforce in mental health. We have to do more to support our peer specialists and peer counselors and those with lived experience. Embedding equity and building the suicide prevention workforce. I particularly am fond of this resource because I worked on this with my colleagues. And as a result of this, we have a virtual town hall that came about with a number of recommendations in suicide prevention of how we can address the disparities in suicide prevention. So I'd be excited to share that with you too. An analytical report that also just recently was completed. We're waiting for it to get cleared before it becomes public. So this is the TBD. Capacity and equity gaps of the clinical suicide prevention workforce. So if you work in suicide prevention, crisis intervention, you know that there's a critical need of shortages of clinicians in terms of addressing the needs of underserved communities. And then SAMHSA funded Centers of Excellence programs. The African American Center of Excellence is just one, but we have COEs, we call them COEs for short, for older adults called the E4 Center. If you literally Google SAMHSA Center of Excellence, a whole host of them are going to come up. They are population specific and they are wealth of resources and information. Next slide. And I got ahead of myself. And there is also the list of the Center for Excellence for Integrated Health Services. This is operated by the National Council for Mental Well-Being. They're really good at providing consultation, learning and mentorship, and workforce-related webinars. And I wanted to make sure I underscore that. I'm going to move to the question and answers section pretty soon. So you can start to put your any questions you have in the Q&A section. I also wanted just to share that we had in 2022 a publication of evidence-based resource guides, burnout and behavioral workforce through organizational strategies. And so I don't need to tell people who work in the public sector and helping professions about burnout. You probably know way too much that you care to. But I also want to let you know that there are resources available around preventing burnout or coming back from burnout. And I think now there's a lot more emphasis in the workforce about self-care. So I hope from me to you that all of you are doing everything you need to do to take care of yourself. I would hate to hear about anyone getting burnt out who really love this work. Next slide. And I think this is it, the reference presentation. Next one. Thank you, gracias. I appreciate the time. Next slide. So now we have time for questions. What questions do you have?
That's fantastic, Dr. Tiswell. Do you want to manage your Q&A? Do you want to do it, or do you want me to ask the questions for you?
Can you ask it for me? I appreciate it, Danny.
Yeah, absolutely. This was fantastic. This is definitely one of the things that I think a lot about. I spend a lot of my time and career focusing on the idea of workforce. Here is a fantastic question. How can we help leverage interstate agreements, counseling compact, etc., to help increase access to services, especially when considering different cost of services and insurances across the state?
Excellent question. So this is going to be a multi-pronged question, or multi-pronged response, I should say. So one is that when I think about the Compact Act in terms of interstate compacts that are being developed, I think about how far we've come when it was just a kind of a concept, a proposal, and now you're starting to see it really become a reality. One thing that I would encourage folks to do is to be aware of what your state block grant offers. Many folks do not necessarily know everything that their block grants cover. And there can be modifications made from one year to the next where you can request that certain things be included to SAMHSA in terms of how we can include other services. That's how peer services got covered in the block grant. And so I want to just encourage people, know where the money's coming from. and if you don't necessarily have access to that, the other thing is I would definitely encourage, every jurisdiction is a little bit different, but find out who are the leaders and shakers, who are the movers in these spaces, because if you have close proximity to them, you get really close to understanding what the issues are and what the issues that are not being spoken are. And part of this is all relational. I'm a big believer, having worked in government for nearly 12, 13 years now, that, it's all about relationships. It's about relationships. It's the things that our mothers and fathers told us as children: go to school, play nice, be sweet, play nice in the sandbox, right? Those things carry over to adulthood.
Fantastic. Here is another one. Are there resources you could share for newly created DEI groups? We have one at our agency and are always looking for resources to expand our understanding and knowledge for best practices.
Awesome question. First of all, congratulations on your newly developed group. I'm not quite sure of the context for DEI, so I'm assuming that it's behavioral health or mental health maybe. And so what I would do is that if I can toot the horn of our colleagues at SAMHSA, but also at CDC and at HHS, the Health and Human Services Department, is that do a Google search for Centers of Excellence, SAMHSA. Now, I'm giving us a shout out first because I'm most familiar with these resources. So SAMHSA funds what we call Centers of Excellence around the country. They're generally affiliated with a university. So they have access to researchers as part of these COEs, the Center of Excellence. And they provide training, technical assistance, resource development specific to the populations they're serving. So if you are so we have a Centers of Excellence for Hispanic Latino communities, for LGBTQ plus communities, for Native American, Hawaiian, Asian American, Native Hawaiian. We have for the older adults. So they are very selected, very specific, population-specific Centers of Excellence, and that's all that they do. And if they don't have a resource that you're looking for, you can make a request that they develop it or investigate it.
Excellent. I've got one more. Do you offer organizational trainings, specifically helping to build anti-racist structures and policies? Thank you so much for your expertise.
Oh, thank you. So our agency as a whole, we do a lot of trainings, presentations. There is a number of summits, a lot of speaking engagements that we get. So we do accommodate that. The short answer is yes. In terms of organization, there are, like, if there's an organization that's requesting a specific training, oftentimes what we will do is that, because sometimes the experts are not within SAMHSA, sometimes the experts are external that we may have relationships with, and we will try to connect the dots to people. But there are also a great deal of experts at SAMHSA. I'm proud to work among them.
Okay, one last.
Okay.
One last. What are some strategies that organizations can utilize to support current healthcare workers of color?
Oh my goodness. Now that's the last question. That's the biggest one, right?
Right.
So I think this is a multi-pronged response as well. One is that whenever there is an opportunity in the workplace in particular, I would say try to see if there can be development of an affinity group in the workplace. Oftentimes, the employers are not aware of the need until it is raised, right? And so I think people, when they have a collective voice, they're much more powerful, and there's a lot more opportunity to kind of come together. Again, in a whole different context, we have affinity groups at SAMHSA, and oftentimes we meet around workplace issues, around topics that are coming up for professional development. And in one of our recent meetings, people talked about how did you become promoted to this job? I want to go into this job. So we have very practical conversations too, right? Like, what's the pipeline to get promoted, right? What are the opportunities? So I encourage that. The other thing is, I'm a big believer in having offline discussions. Is that if you see people in positions that you would like to be in, or people that have been in a workplace setting for a number of years prior to you, those are the folks who have the wisdom that you cannot buy on Amazon, right? Those are the individuals that you really want to engage and talk to. And so sometimes you have to, like, hey, let me take you out to lunch. Let me get you a cup of coffee and let's have an offline conversation. I'm a big believer in that, right? Because none of us are going to be around long enough to make all the mistakes and to find out all the knowledge before we retire. So let's take advantage of those resources, meaning people who are around us and are willing to share. The smartest thing I ever did was to, whenever I go to a public event, for a workplace event, I find the table or the chair next to the people who have been there for a minute. Like, I can socialize with my colleagues anytime, but I'm going to see who's been there, right? And that's one of the things I think we don't do enough of, just collectively. And the other thing I'm going to just say, and this is more of a Walker Tisdale response, not a SAMHSA response. So let me make that distinction. Fix my glasses with that. Is that if you're in a position to where you're able to have substantive, meaningful, authentic conversations with your direct supervisor or someone in your immediate line of supervision, I would encourage you to do that. Because again, I think one of the things in terms of workplace and how we can support each other and develop is that we have to let folks in leadership positions know what you're experiencing. And I think that now their response is something else, right? But you have to be willing to let them know. And there does go, to do that does require a level of trust and engagement. So I don't want to undermine that, because if you don't feel that there's trust, or it may be used against you, then it may not be something you want to do. But I'm a big believer is that we have to be more communicative.
Thank you so much, Dr. Tisdale. This has been fantastic.